So first I'd like to thank everybody for participating in this webinar. And as it turns out, this has become one of my favorite ways to teach because I can talk to people all across the world from my office, and it's kind of wonderful. So the goal of the webinar today is to explore the assessment and treatment of one of the most common low back pain problems. Many theories of low back pain have come and gone over the years, and at one time it was thought that most back pain was caused by injuries to the intervertebral discs, and then at another time it was thought to be the quadratus lumborum or the psoas muscle, and then in the 1940s it was thought to originate mainly in the sacroiliac joint region. And over the years, I've come to understand that all of these theories and several more that I haven't mentioned were correct some of the time, but only one of them was correct most of the time. So just in terms of logistics, we're going to be here together for about an hour. I'm going to present material for 30, 45 minutes, somewhere in there. And then I'm going to take your questions. And anytime you have a question, there's a little box on your control panel on the upper right-hand side, and you can hit the little question box. There should be a little plus sign there, and that little plus sign will allow you to open it, and then you can type in a question, and Jeff will receive those questions, and toward the end of the webinar there'll be a time for you to ask questions. Why don't you try right now to click on that question box and just type in hello so you know how to do it, and I'll wait a minute to see if we can make sure you know how to do that. And if there's a time when you don't understand something, I can see those hellos coming in, great. If there's a time when you don't really understand something at all, you could write something to Jeff, and Jeff, maybe you could interrupt me. Be sure to unmute yourself if somebody's really not clear on something. I can see some of the people I saw last time I was in Sydney. Hey, great. Hello out there. All right, so now you know how to do that, and you can now hit the orange, sort of orange-white button that has an arrow. If you hit that, your control panel will disappear to the side, and it'll be small so you can see the screen. You might want to try that now, and so that you can minimize that little piece there. Okay. Now, if I don't get to one of your questions and you feel a little frustrated, you could post a question on my Facebook page, facebook.com/Benjamin Institute, and that way I can answer the question for everybody if I don't get a chance to get yours today on this live webinar. And you can also ask me in person, whether you're in Melbourne or Sydney, because I'm planning to come down at the end of November, beginning of December, and teach again the low back and also the cervical webinar training for about 2.5 days, low back and neck, and then I'm going to teach an active isolated stretching on the upper body and the lower body in the different cities. Okay, so let's have you think about a couple things as we're going through this webinar, questions that you might keep in mind. How many layers of sacroiliac ligaments are there? And what are the most common referred pain patterns when the sacroiliac ligaments are injured? And what are the 2 assessment tests that will be most likely to be painful with this condition, the sacroiliac problem? And what does sciatica really mean? And which position puts more stress on the discs and the ligaments of the low back? Is it standing? Is it sitting? Is it lying down? What is it? And then we're going to cover all these things, just some things to bear in mind as we get started. So let's begin by reviewing some of the anatomy so we're all on the same page. And most therapists learn musculoskeletal anatomy, but often they lack a knowledge of and the skills to find the ligaments and of the fascial network that they're embedded in. I mean, your ligaments are really part of your whole fascial network of support structures, and they're thicker, they have different function, but they're really interwoven with the fascia. And in my recent work with Tom Myers, it changed a little bit of my approach and realized that the fascial component is a little bit more important than I even thought, and I thank Tom for that. And so we're going to talk about mostly the ligaments, but also some of the fascia as well. Okay, so the sacrum is often referred to as the keystone arch. And it's the intersection, sort of the primary connection between the trunk and the pelvis. This kind of connects the upper and lower parts of our bodies. Now, this crucial connection became very vulnerable in humans as we learned how to stand and walk on 2 legs instead of 4. And another major change in the use of the back occurred really very recently in our recent history. We began sitting for hours and hours and hours and hours at a time. Now, our ancestors didn't do a lot of sitting. They would walk around a lot. They would be hunting. They would be gathering. They didn't have a lot of chairs or lounge chairs or couches to sit around on. So mostly they were active. Now, sitting is something the entire spine does not like when it continues for long periods of time. Now, in fact, the greatest stress on the low back is in the sitting position. Now, it stresses the sacral ligaments as well as the discs. When we stand or walk, our weight is distributed throughout our lower body, and when we sit, much more pressure is exerted on the discs and the ligaments of the low back, particularly if we slump down. Now, most people don't have a good posture when they sit. Some do, but most don't, and it puts a tremendous pressure on all of the low back structures, including the muscles, the fascia, everything. The low back is the most commonly injured part of the human body. Now, this isn't a recent development. In ancient Greek and Roman times, we saw drawings and pictures of these horrible-looking traction devices that we know, people use for back pain. And learning about the low back and all its complexity takes a lot of time. And when I train therapists, you train them for 2, 3, 4 days, teaching assessment and treatment of the low back. Now, people often go back and study even more and work for 20, 30 more hours practicing. When people study my DVDs, they usually spend 30 to 40 hours working with it to really perfect how you find the structures, how you test things, all the various things you need to do to really assess and treat a low back. And today we're going to look at the most commonly injured structures of the low back. There's a lot of different parts, but we're going to concentrate on the sacroiliac ligaments. So there are 3 layers of sacroiliac ligaments. First, there's the posterior ones up here in the upper left, and underneath those are your interosseous ligaments, which are here on the right, and then deeper still are the anterior sacroiliac ligaments. And I'm going to talk about the fibers in a little more detail. Your fingers cannot reach anything but the posterior fibers, the ones that are on the surface. The posterior sacroiliac are located in this little depression over here, in the deep depression that's between the sacrum and the ilium. And they're very, very strong, and they form the chief connection between the sacrum and the iliac bones. And they consist of numerous vesiculi, or bundles of fibers, which pass between the bones in various directions. The upper fibers are referred to as the short posterior sacroiliac fibers, these ones on the top over here. And they're almost horizontal in direction, some of them, and they pass from the first and second transverse tubercles, those little bumps that are on the back of your sacrum, to the tuberosity of the ilium. And the lower fibers, which I'll show you in a minute, are called the long posterior sacroiliac fibers, and they travel in an oblique direction. And they're attached to the third transverse tubercle, or that bump on your sacrum, to the posterior superior spine of the ilium, also referred to as the PSIS, way up here. And in total, the sacroiliac ligaments consist of hundreds of thousands of fibers. And here's another illustration to make it a little clearer. The uppermost horizontal, these red lines over here, actually, this one on top is the iliolumbar ligament that gets its own webinar or own little training as we do this. And then we have the short ones, which is on a diagonal this way. And then we have the long posterior sacroiliac ligaments that go actually almost vertically. And then down here, we have the sacrotuberous ligaments, sacrospinous ligaments, which we're not going to cover today, but in trainings we cover all these in great detail. And, when people are just hurt a few of these fibers, a few dozen of these fibers or so, these ligaments can become so inflamed, it can create actual agony in a person's life. I mentioned earlier I had pain, and it turned out that's what I had. I didn't know it for many years until I met the doctor who finally really explained it to me, Dr. Ongley. And, when you just touch yourself or you move in a little bit of direction, you can be, in tremendous pain. Now, if you've been working in the field for any length of time, I'm sure you've seen people in extreme low back pain. I was just teaching a workshop in the Midwest 2 days ago, and one person, she said just lying down sometimes creates such a bad spasm that she couldn't move. So she lied down, and of course she went into spasm, and by the time the day was over, she was feeling a little better. But it's a horrible kind of thing to experience. So in order to effectively assess a low back pain, it's crucial to have an understanding of referred pain. So let's spend a few minutes on that. Referred pain is a pain felt at a distance from its source. The pain's in one place, and the source is in another place, or the injury is in a totally different place. And there are 4 rules or 4 guidelines of referred pain. And the first one is pain refers distally. So that means if I get a pain in my low back, it will refer down into the buttock, the thigh, the calf, or the foot. But it doesn't refer up. It doesn't go up your back. And if you get an injury in your neck, it will refer down your upper back, down your shoulder, down your arm to your hand, but it doesn't go from your wrist, up to your neck. So in orthopedic medicine, and there are many different systems on this, but in orthopedic medicine, if you follow that guideline, there's some water in here, then you'll really understand, what's happening with the pain from various structures in the low back. The second one is that pain doesn't cross the midline. You don't get a pain in the right side of your low back and goes over to the left side of your back. If it does that, what do you think it means? If you have a pain in the right side and it goes over to the left side, what is that? What is the client actually telling you? Why don't you type that into your little question box so it can have a little interaction here. What do you think it means if it goes from one side to the other side? All right. Yeah, somebody's saying, what about coming to Newcastle? We'll come to Newcastle if you get 20 people. Just talk to Jeff about it. Okay, so someone says here, the person has ligament problems, maybe. Another person saying it's a different source of that pain. That's absolutely right. And somebody says the person has 2 problems. They got an injury on one side, and they got an injury on a different side. Exactly. So they have 2 different issues. And it could be the sacroiliac ligaments, that it's injured on both sides of those, or it could be the iliolumbar ligament, sacrotuberous ligament, could be all sorts of things. But it means there's not just one problem. And one of the secrets of the sacroiliac is that it can hurt on either side or both sides at the same time. If you have a disc problem, it doesn't do that. So let's go on to the third guideline of referred pain, and that is that it moves and refers in the dermatome. Now, dermatomes are these embryological aspects of ourselves that form our entire bodies. And when you're in an embryo, your body consists of 32 parts. And then each part develops the various parts of our body. And you can see here, this is a particular one right here. And it shows the referred pain would go to the big toe, would go on the inside of the leg, the center of the thigh. And so if you know your dermatomes, you get a good idea which of the ligaments or discs, etc., are causing the problem. So if you know your dermatomes, it gives you a better sense of things. So just as an example of that, when you get a heart attack, I hope you don't get a heart attack, but when a person gets a heart attack, where does it hurt? Sometimes it hurts in the chest, but most of the time it hurts in the left arm, because the heart and the left arm are made of the same dermatome. So the brain interprets the pain, and that's why we feel the pain in that particular region. We discovered this in the end of World War I. So many people had lost their legs, but they complained of pain down their leg and in their feet even after their leg was gone. So we realize that it's a brain phenomenon, not necessarily a local phenomenon when you feel pain down your leg or down your arm, etc. And then the final guideline or rule of referred pain in orthopedic medicine is that the distance the pain refers is directly proportional to the severity of the injury. So that means if you've got a really bad one, it's going to go all the way down your leg. And if you have one that's, not as bad, it hurts some, but the pain isn't terrible, it's going to maybe just refer pain down to your buttock or maybe down to your mid-thigh. And that's how we understand the distance the pain refers is directly proportional to the severity of the injury. Now, this is really cool because when you're working on somebody's, let's say, posterior sacroiliac ligament on the left, and you're actually anesthetizing it as you work on it. And as you work on it, sometimes the pain actually recedes up the leg. I remember the first client I had after I took the Dr. Siriax's workshops, I had somebody who had a supraspinatus injury in the shoulder, and they had a pain all the way down to the wrist. And as I worked on the tendon, my first client, the pain started receding up toward the elbow. And that was great for me, not just for the client, because I was doing this new thing, and I didn't know if I exactly believed it. But after I started having that experience on various people, I realized, what I was doing was directly affecting their pain. Now, of course, it didn't go away completely right away. I was just anesthetizing it. But after several weeks, the pain kept creeping up toward the shoulder and finally was gone after about a month of treatment. That's a nice way to start, because you can't help everybody. You help most people, but you can't help everybody. So let's move now on to the assessment process. Now, skillful assessment is crucial to effective treatment. And now we're going to cover the most important tests to assess if there's damage and scar tissue in the sacroiliac ligaments. There are about 26 tests that we teach you in the workshop, but here we're just going to do a very few. Because when we do a full training, we're trying to differentiate what's going on here. We want to know, is this a disc? Is this a muscle? Is this something in your ligaments? What's going on here? And we do much more extensive testing, which isn't realistic on a webinar format. All right, so before we get going into that, let's take a moment and talk about adhesive scar tissue, which is really the primary source of pain in ligaments, tendons, muscles, and fascia. Now, this is an illustration of well-formed, painless scar tissue that binds injured fibers together well. In this case, the fibers can slide on each other because they're not kind of glommed up together. It's just like a good repair job. And the person was lucky, or they kept moving. They didn't just freeze themselves. And they've got well-formed scar tissue. Now, if we go to this illustration, this shows poorly formed, painful adhesive scar tissue that binds the injured fibers together in the wrong direction as well as the right direction. And every time the person does something, it repeatedly tears, forming more and more painful scar tissue. And if you have taken detailed histories of people with low back pain, they say, oh, it started out 10 years ago and would come once in a while, once a year for a few days. And then it started to be once every month, stay longer, a week, and now I have it all the time. Can you help me? And this is a very frequent scenario of scar tissue formation. So let's now move on to the tests. Now, this is active flexion. Now, it starts out active and it becomes passive as we let gravity take our body toward the floor. And you ask the person to tell you if they have pain during any of these tests, and to stop and return to the starting position as soon as they have any difficulty. So if they bend just an inch or 2 inches or 3 inches and they have pain, they should come back. Now, sometimes people have pain just standing there because they're in a state of pain all the time. So they're standing there and you say to them, okay, I want you to tell me if your pain gets worse. So when you bend down slowly, if you bend, like a foot and it hurts you, stop, don't stay there, come right back up. And that goes for every test that you're going to do. You don't want the person to be in pain, but you have to have the test demonstrate some pain in order for you to know, what's happening. So let's go to the next test, and that's extension. You ask the person to bend back. And flexion and extension are the most commonly painful tests when a person has a sacroiliac ligament problems. There are many other tests we do to eliminate discs, but these are the two tests that show you, in most cases, that the person has a pain in the sacroiliac ligaments. So there are many other signs that we'll get into, but that's in terms of the testing. They'll also show you where it hurts them, and that's going to give you some of the clues where the pain refers. And also you do the tests going side to side, and sometimes that pulls on different fibers of the sacroiliac region. So you bend to the right, you bend to the left, and you see if that hurts the person. Now, as the person gets better, then you're going to know when they do these tests, it doesn't hurt. And also they're going to tell you when I sit or stand, etc., it doesn't hurt me anymore, or it hurts me less, or I can sit longer, I can stand longer, I can walk longer, etc. So this is another test that's important, because hip joint problems can be mistaken for low back problems, and because sometimes people will get a pain in the buttock area, particularly on the lateral area, where you can refer pain from a back injury. A person could have only pain in the lateral hip and not in the back, and that's also one of the signs of a hip joint problem. So what we do is, when we're doing a low back test, we also do a couple of tests for the hip joint, so that we make sure we're not mistaking the person's injury for a hip joint problem. And there are two tests that I'm going to show you to do that. So first, they're going to lie down on the table, and you're going to bring their knee toward their chest. I'm not pushing down on the person's ankle, I'm pushing down on their knee. And so I want to see if it hurts them in the front or outside of the hip, so that we can, get clear that this isn't a hip problem. Now, if it hurts in the back when you do this, because this might hurt in the back, because what you're doing when you do this is you're mimicking flexion. So if when the person was standing up and you had them bend forward, they had a pain, this might also hurt them. In a moment, I'm going to talk about how you can make sure that that's not what it is. So you make sure you ask them where it hurts. So let me show you the second test, and then I'll show you the other trick here. Next is medial rotation. So what I'm doing is I'm making the thigh vertical, keeping it there, and I'm medially rotating the thigh at the hip joint by pulling the calcaneus toward me. Now there's a short little video with these tests from my low back DVD series, and I'm going to give them to Jeff to post, or he'll give you the address also, so you can watch those little ones. You can go to my YouTube channel and find it, but we'll give you the address directly. Okay, so what you do if you're having trouble, so you do either of these tests, the one I just showed you here or this one, and the person has pain in the back. Well, what's happening is their back is flexing a little bit with either of these tests. So you tell them to make a fist and put it under that side of their lower back. And then you do these tests again, and in 98, 99% of the time, the pain will be gone because the body's not going into flexion, or the pain is greatly diminished because there's a little bit of push on it. Okay, so that's how you eliminate that there's a hip joint problem. Okay, so now here's another picture showing you that. We're going to move on to the theory, where we kind of put all the information together. So in the cases of sacroiliac ligament injury, the assessment tests will generally show, pain when the person bends forward, or pain when the person bends back. You could have either one of them. One's called a flexion pain, and one's called an extension pain. Now, if the person has an extension pain, you have to be really careful when they lie on the table on their stomach when you're treating them, because if the person lies on their stomach and you work on their low back, you're going to be pushing them into extension. And many therapists have had the experience of a person lying down on the table and not being able to get up without excruciating pain. And this is because when you do massage on the low back, you're pushing it into extension and you're exacerbating whatever structures, could be the sacroiliac ligaments, could be other ligaments in the low back, that get more and more inflamed as the treatment progresses. So to eliminate that problem on people who have what we call extension pain, you put a pillow under their abdomen when they lie down, so that the back will not go into extension as you do your work. Now sometimes side flexion is painful also, but these are definitely the most painful. When it's side flexion, it's another ligament that's at fault, and we'll get to that in another webinar if you're interested. There's a whole series of webinars. If you can't come to Melbourne or to Sydney to do these trainings, we have things on DVD on my website. We have other webinars, but of course it's the best to do it in person. So now we also look at what's a common referred pain problem when you have a sacroiliac ligament issue, and this gives you a lot of information as well. And there are 3 common referred pain patterns that you might see in your clients with sacroiliac pain and dysfunction. This one, pain across the low back on both sides, the very lowest part of the back, is the most common pattern. And people just, that's where they feel pain. And you're going to see this in thousands and thousands of people over your career. Now the other one that's fairly common is pain that's into the buttock, as you see here on the left. That's very, very common in ones that are a little bit milder. And then the more severe is pain down the thigh, the lower leg on the right. And it can be in various configurations. It could go down the side of the leg, the front of the leg, etc., all the way into the foot, the toes. It could be various configurations, but it's referred very far, and as you recall, the further the pain refers, the more severe the problem is. So let's talk about sciatica. The term sciatica is often used by professionals and lay people alike. And let's take a moment to clear up the myth of sciatica. Many people think that sciatica is a precise diagnosis. That means the sciatic nerve is being pinched by either a disc or a muscle, sending pain down the leg into the foot. Now, in fact, the simple definition of sciatica is here on the screen, that a pain into the buttock, down the thigh and lower leg, or all the way into the foot. Now, this type of pain can be caused by many, many, many different injuries, not just the sciatic nerve. So the sciatic nerve actually consists of 5 separate nerves. L3, L4, L5, S1, and S2 are bundled together. If you've ever done dissection, it's really quite a sight to behold, to open up that bundle and view all the different nerves. You never mistake it again. And it's very, very rare for all 5 of these to get compressed. Generally, it's just one of them. And only after they, they're not in the sciatic nerve as it goes down through the buttock and into the leg. It's before. It's really in the low back as they come off the different vertebra through the intervertebral foramen. A disc pinches one of them. You can have 2, but very rare. And so the true sciatic pain is caused by a compression of one of those nerves. However, the orthopedic physicians I know and neurologists I know say that only 3 to 5% of the cases of sciatica are caused by discs pressing on nerves. So what's causing the other 95 to 97%? More often pain down the leg is caused by injuries to other structures, such as the sacroiliac ligaments, the sacrotuberous ligaments. One muscle, the gluteus medius muscle, puts pain down the outer calf. The iliolumbar ligament puts pain down into the buttock, the lateral thigh, into the groin, and even into the genital. Or the hip joint can cause pain down the thigh, up to the knee, and so forth. And of course, the fascia covering all these structures can also cause referred pain if they're at fault. So you see there are many, many, many reasons to have pain down the leg. The least typical is a pinched nerve or a pinched sciatic nerve. And if that were true, most of us would not be able to help people. And I'm sure all of you out there, when you treat people, lots of them get better. Lots of them get your treatment, and somehow their back gets better. I remember when I was starting out, I would do everything I could think of. And, lots of people would get better, and some people wouldn't, and I wouldn't know the difference. And so when I met Dr. Syriacs and Dr. Ongley, and I learned that, what I was thinking, I wrote a whole book called Are You Tense, that everything was muscles. That was only a small part of the picture. when I learned about the ligaments and I learned that I could actually treat them, boy, my practice just took off in a whole different direction. People were coming to me from all over the place to have that work done. So let's go into now the different types of sacroiliac stories that you're going to hear. One is the sudden onset, then no pain, and then a slow onset with increasing frequency of painful episodes. Then there's excruciating pain that goes away, and then there's chronic pain, either mild or really severe, that can remain for a person's entire life. I've seen people have pain for 25, 30 years. And when you're evaluating a client's pain, you want to consider not just, where the pain is located, but, how the pain came, if the pain tends to come and go. So we're going to go through these various stories one at a time so you get a sense of, what that's like. So my office is near a train, so if you heard some train rumblings, that was it. Okay, so first scenario is the sudden onset. Person's doing nothing, they make an unguarded everyday movement, they bend down to pick up something, they like some soap in the shower or, a pencil off the ground, and it precipitates severe low back pain with or without pain in your leg. And the individual is completely incapacitated because the pain is so intense, they need to lie down on the floor or bed or couch, and they have to rest until the pain subsides. Now, this might take several hours, several days, weeks. The pain might disappear as suddenly as it came, or it might lessen gradually over time. And this may, be over, again, different amounts of time. Now, if the pain goes away suddenly, it's likely that the person's sacrum was misaligned, which placed added torque on the ligaments and caused them to tear. And when the sacrum realigned, that stress is removed and the pain just disappears, at least temporarily. And if the pain resolves really gradually, it's more likely that the ligaments had become fatigued and strained over time, like from prolonged sitting. So bending forward to pick something up was the final stress that tore these weakened ligaments. And when this occurs, the ligaments can heal well, but they're more likely to heal with adhesive scar tissue, which increases the risk of future tears over a long period of time. Now let's go to slow onset with increasing frequency of painful episodes. So the person experiences repeated painful episodes that are not terribly severe, but that they occur with increasing frequency. For example, a person may have their first incident of low back pain, let's say when they're 40, and the next one when they're 45, and then when they're 46, 47, by the time they're 50, the pain is now once a week. So this pattern suggests the presence of adhesive scar tissue that's stretched, and you have loose sacroiliac ligaments, and these are stretched gradually over time, making the sacrum unstable and the ligaments more vulnerable to injury. Now, ligaments are supposed to be tight, not loose, to hold your bones together. And this can be precipitated by activities like sitting or bending or lifting heavy objects, particularly by bending forward and lifting them, not using your knees. And in some cases, the pain changes from right to left during different episodes or the same episode. And usually there's an awareness of an annoying discomfort most of the time, even when there's no major, horrible, excruciating pain. It's just annoying kind of discomfort in the low back, particularly on sitting or on standing for a long time. Now, this condition is kind of considered more of a nuisance than an injury by many people, even though the person's life becomes quite limited by it, but they learn they can't do certain things. So the third scenario is kind of excruciating pain, where the person gets fixed in deviation and it slowly diminishes over time. So you're doing something physical, you're digging in the garden, you're lifting weights, you're shoveling snow. But do you have snow down there? Maybe you don't have snow down there. The person suddenly, does something, they become fixed in an abnormal position, like they're bent into flexion forward and they can't straighten up, or they're bent to the side and they can't straighten up. They look kind of distorted, and they are. And if they try to move out of it, it hurts a lot. And so the body's telling them not to move. This happened to me once. I couldn't straighten out. I sneezed, and I was bent over for several days when I was much younger. And in medicine, that's referred to as deviation. So that's why it's called that, because your body is deviated. And any attempt to move causes excruciating, intense muscle spasms that give you the message not to move. No position is really comfortable, and this state may last for hours, days, or longer, and it usually abates very slowly over some time. And this is often a really frightening experience. The person's body is immobilized, distorted, feels out of control, and let me tell you from experience, it is not a fun experience, one that I only had a few times in my life, but now never again. And let's come now to the fourth and final scenario. It involves persistent low back pain with or without leg pain that lasts for years and years and years. It could be mild, it could be very severe, but it's chronic. And usually the first onset is sudden. It's precipitated by an activity like sitting for a long time, bending or lifting. The person tries many different medications, therapies, possibly including surgery. Nothing helps. It wasn't the disc, it was something else. There are two very different scenarios in this scenario. The first one is they're in constant severe pain that has altered their life, their mental state, their depression sets in, they can't do anything, and the person sort of operates in survival mode with very high levels of stress. And the second is thankfully more common, and that is a constant low level of pain. It's not debilitating. Sometimes it gets worse and better, but again, it significantly alters the person's life. So here's a picture of what I was talking about before to make sure it's not a hip injury. Just to review that, when you're doing flexion and medial rotation, you put the fist under the back if they have pain in their back when you do this particular tests. It prevents the back from going into flexion. Now, another issue is sometimes there's a pain down the back of the thigh and even up into the lower buttock, and it could be coming from the sacrum, but it could also be coming from the hamstring. So what you do is you test the hamstring. I was just teaching over the weekend in Wisconsin, and there was a person that we had come in who had a pain down the thigh. Well, a pain down the thigh doesn't have to come from the back, so it was kind of perplexing to the students. They said, well, this is just a hamstring injury. So when you do a resisted motion, like pulling the heel toward the buttock here, and you get pain in your thigh, that means it's a hamstring tear. Now, if the person, is just standing there and they're not doing anything, or they're lying in bed and they all of a sudden get the pain, that's a little different. So there are ways to differentiate, but this is one way to differentiate a hamstring injury from a low back injury. Okay, and there are also things to look for with the discs, which we'll get into in a moment here. So, this chart helps you differentiate disc from ligament injuries. And so we'll go over the disc injuries first here. I'm going to make it a little bigger. So here we have disc injuries, only a small percentage of the time, 2 to 5%. You have unilateral weakness of a specific nerve root. That means, okay, so your L5 is gone, and you can't move a certain part, you can't do a certain movement of the foot, or your L4 is gone, you can't move one of your toes without a lot of weakness. And also it may involve reflex changes of L3, L5, S1, S2. You have referred pain within the dermatome, and it is kind of distal, maybe down the lower leg of the foot. And you have also something called asymmetrical limitation and pain. So for instance, you can bend forward fine, but you can't bend back at all. Or you can bend back fine, and you can't bend forward at all. And this is what happens when you have a disc. One area is free of movement and another one is severely terrible. And then there's no pain on palpation unless the ligaments are injured as well. Now the ligaments, are, I would say, 85 to 90% of low back injuries. There's maybe a general weakness in the legs because you don't do anything. You sit on the couch because everything hurts. You don't really have reflex changes. That's very rare. They might be diminished slightly, but not terribly. Referred pain is within the dermatome, but usually it's proximal. It's into the buttock and the thigh, not so much in the lower part of the leg, unless it's really severe. And pain and limitation is on articular movements, meaning bending forward, back, side to side, and it's not more limited in one direction than another generally. And the pain is local. When you touch the ligament, it hurts, and it may be referred for some distance depending on the severity. So let me go to a slightly different thing that I think is important to understand about the whole body, and particularly about the low back. When you're assessing something, you want to keep in mind that there are these two different causations. There's direct pain and indirect causes of pain. For example, a ligament is generally a direct cause of low back pain, or a muscle tear might be a direct cause of low back pain, or a disc pressing on a nerve. An indirect cause might be a misalignment of the pelvis, a short leg from a chronic contraction of the psoas or the QL, quadratus lumborum, or poor lower back alignment like extreme lordosis or sitting for long periods of time. It's important not to get these two causes confused. Both are important and need to be addressed, and if you're going to permanently get rid of the pain, you want to be able to address both different types. So when people come and they say, well, my back hurts because my alignment's bad, I say, yeah, that's right. That's how it caused it, but right now it's because your ligaments are torn, and that's the first thing we have to get rid of. So once you've determined that the sacroiliac ligaments are injured, there are many different treatment options that you could choose, and I'm going to talk about a few of the ones that I find the most effective. First is friction therapy of the sacroiliac ligaments. It breaks down that adhesive scar tissue that causes most lower back pain. Now in the 1980s, when I worked with celiacs and I learned about the friction therapy from him, and he was called the father of orthopedic medicine because he learned how to diagnose and treat all non-surgical approaches to musculoskeletal pain. And I realized that I was doing shoulders and elbows and wrists and knees and ankles and muscles, and realized that he was saying you can only treat the low back pain by injection or manipulation or other means, and I said, or traction. So I tried out this friction therapy that I learned on the ligaments of the low back, the mid back, and the neck, and it was incredibly effective. So that's what I've been teaching for all these years, what my videos contain, etc. So friction therapy, great for treating these kinds of pains. I remember I had a rolfer who called me up after hearing this series of webinars and said people she'd been treating for 15 years still had their low back pain, but after she saw this series of webinars, she got most of them completely better in a couple of months, and she wanted me to send her everything I'd ever done, books and videos and everything, because she wanted to really understand this work thoroughly. So, second, myofascial work, important to include in your treatment. All of the ligaments are encased in fascia, and in fact, the ligaments are part of the fascial network, as I said earlier, and restrictions in the fascia of the thorax or the neck could be part of the underlying indirect cause. And of course, the fascia that overlies the ligaments and the buttock, etc. So before you start your friction therapy, if you know how to do myofascial work, do that first before you go to the friction therapy. And then, of course, I finish it up with massage therapy to feed some circulation, relaxation to the area. And then I use this incredible technique of Aaron Mattis, who put together a series of stretches that really creates tremendous flexibility in the entire body. And I like to teach both of the things. When I'm teaching the low back, I like to teach it with active isolated stretching. And the courses that we're going to do in Melbourne and Australia will have 2.5-day courses, one on Aaron Mattis's work and one on the celiac's work of assessment and treatment. Because if you don't have flexibility and then followed that by good amount of strength, with flexibility, you're going to get injured again. Aaron actually developed 175 stretches, which usually take 4 or 5 hours to complete. But we don't do all those. We just do an hour or 45 minutes, ones that are directed toward where the person's problem is. And I'm a very skeptical person, and I've not learned new things that are often that really change my work. This was a revelation to me. Aaron's work was very powerful in helping my clients to get better faster and stay better. So here he also has a series of exercises that I also teach. Here we're working on the psoas muscle, here the abdominal muscles, quadratus, etc. Really great set of exercises to add to your toolbox. Also, sometimes I will refer people to corrective movement therapists, the Alexander technique, Feldenkrais technique. Good to have those kinds of people in your referral network so that people can learn how to move better and not get hurt. Okay, so this is some referrals that I use, and here you have the Angley Institute if you're interested in looking at the treatment that the doctor that I trained with does, the injection therapy called Prolotherapy. So let me just tell you the dates of when I'll be down in Australia, and then we're going to take your questions. So if you have your questions, I'm going to take them in a moment. You can just start submitting them to Jeff. In Melbourne, we're going to do the assessment treatment of neck pain, which we did in Sydney last year, not last year, a few months back. And we'll do that from November 28th to 30th, 2.5 days. And then we're going to do active isolated stretching of the entire upper body, the neck, the shoulders, etc. We'll do that the following 2.5 days, November 30th through December 2nd. And then in Sydney, we're going to do the neck, because, no, did I have that wrong? Did I have that backwards, Jeff? I think I have that backwards. I think we're doing the back in Sydney, and we're doing the neck in Melbourne. I got it backwards. See? You don't learn unless you have mistakes, and those were mine today. But
yes, that's right.
And in Sydney, we'll have it'll be December 5th through 7th, and the active isolated stretching for the low back will be the 7th through the 9th. So I hope I didn't confuse you. But we're in Sydney, we're doing the low back, and in Melbourne, we're doing the neck and the upper body. And we have all sorts of webinars on my website if you're interested, by not only me, but Tom Myers and Whitney Lowe and stuff on cancer, pregnancy, etc. So now I'd be happy to take whatever questions you have and straighten out any confusion that I may have caused, or things may not be clear to you. So we have some questions, Jeff.
How long and how deep do you do friction therapy on the ligaments? I've been doing this, but I'm not sure for how long. I've also found balancing the joints helps to mobilize them a lot as well.
So when you friction, you need to do it for a prolonged period of time. So if you're working on this, if the only thing the person has is sacroiliac ligament problem, I would do 5 or 6 minutes. Keep changing your hand position, and you'll get access to a little video clip on my YouTube channel to learn how to do this. But of course, better to have it in person to get it really right. And so you do it for 5 or 6 minutes, then you take a little break for a couple minutes, and then you go back and you do it again. And if it's only on the right side, do the right side. If it's on both, do both sides. And certainly balancing the joints, doing some myofascial work, doing some stretches, etc., all important things to do. So the total is sort of 12 to 15 minutes of friction on the ligaments each time you see the person, and that should be probably a couple of times a week is the best. Next question.
One from Michael a bit earlier in the piece, relating to muscle tension and it's splinting the problem. Is there any issues in exacerbating the problem by removing the muscle tension that's causing a splinting or protecting an area?
Great question. Because the the splinting or the spasm is a protective measure, you don't want to get rid of the spasm. And actually you can't get rid of the spasm because the body has an automatic protective mechanism. So if you move your body in a particular direction that's causing more stress on the ligaments, it's going to automatically cause a muscle spasm. Now, doing some massage to lessen the stress, to increase the circulation is great, but you're not going to be able to lessen the spasm. Don't try. You don't want to. You want that spasm to protect the person. You want to get at the cause of that spasm, which is, in many cases, the sacroiliac ligaments, in other cases, the iliolumbar ligaments, in many cases, the sacrotuberous ligament or the supraspinous ligaments. It could be all sorts of things, or it could be a combination of all of those at one time, which is very, very common. It's common to have several different ligament injuries. So you do not want to get rid of the spasm. Don't try. Do some gentle work on the entire back, on the legs, on the buttock, after you do the friction treatment.
Peter has one. How do you strengthen ligaments besides using prolotherapy?
Well, what you want to do is you want to maintain the integrity of the ligaments. And when you do the treatment, one of the things we give people is a stretching procedure, very gentle, where they're sitting in a chair and stretching forward 50 times, 2 or 3 times a day, very gently. So you put tension through the ligaments. You know, one of the things they noticed when they put people up into space is they noticed that their bones would begin to atrophy and their muscles begin, everything atrophies when you don't put weight through it. There's that saying, if you don't use it, you lose it, and that's very true. So you can't tighten them with anything, in my experience, except by proliferant therapy, which stimulates the growth of new collagen and tightens your ligaments 30 or 40%. But you can maintain their strength. And if a person doesn't have excessively loose ligaments, you get rid of their ligament injuries, they'll be fine. But if they're very loose, and they were, you know, when they were a kid, they were called double jointed. Of course, they're not double jointed. They just have ligaments that are longer than most people, so they have excessive motion at the joints, which is dangerous. You know, most of the gymnasts that I've treated have very severe, you know, injuries in various parts of their body because they don't have the normal protection of the ligaments, which are supposed to be tight to hold your joints in place. So, and if you discover some way to tighten the ligaments, let me know. I'd like to know. Then people wouldn't have to get those injections to tighten up their ligaments. And I've been looking for something like that for 30 years, haven't found anything yet. But, you know, there are lots of things out there. And sometimes you don't know what they are, and it takes a long time. It took me 22 years to find Dr. Siriax and Dr. Ongley. So maybe there's another thing out there that I don't know about, and I'm really open to finding out.
Elizabeth asks, is the presence of pins and needles and numbness exclusively a disc problem, or can it be SIJ?
If you've got numbness, that means when you touch somebody and they close their eyes, they do not feel your hand. If they close their eyes and you touch them, they know you're touching them. That's what we call numb-like. It's a distorted sensation, and that can happen by ligaments. And if you have pins and needles intermittently, just occasionally, that could be ligaments as well. But if it's constant pins and needles, real numbness, it's going to be a disc. And that's not as common as the others that I just mentioned.
Josie asks, to help manage pain between sessions, do you suggest painkillers or anti-inflammatories? I'm never sure whether it's good to mask the pain.
Yeah. Well, that's a great question. I mean, again, you don't want to interrupt the doctor's work, and you can work fine if the person has excruciating pain and they can't function at all. Yeah, I say, you know, take your painkillers and work with their doctor. They should work with their doctor to slowly diminish their amount of medication that they take. And as we do the work on their back, and I've done this with, you know, hundreds and hundreds and hundreds of people, as you work with them and they begin to feel better. Now, usually when people take medication, they still have pain, but they're going to feel a little better, and so they feel confident cutting down on the medication. But it should be done under the doctor's guidance, because you don't want to cut down medicine too fast and not have a bad reaction. So, especially if they're on heavy-duty medication, they have to do it very slowly under a doctor's guide. If they're just taking Advil, you know, they could do, you know, lessen the dose a little bit by themselves, probably, if they're not doing it under a doctor's guidance. So yes, if they're in excruciating pain, better if they don't, if they're in just mild pain. A question people often ask is, how do I do the active isolated stretching in every session? And I do it as soon as they're a little more functional. Usually after 2 or 3 or 4 sessions, I spend half the session doing intensive active isolated stretches that are very different than any other kind of stretches that I've ever done. So it really increases the flexibility in their hamstrings, in their quadriceps, in their adductors, in their abductors, in their low back, so that they're now have greater movement, lesser danger, and they get better much, much faster, and they get empowered because I give them stretches to do on their own that are much more intense than they've ever done, and very gentle, really. They're not pushy, or they're not, you know, painful. They're just really great. I like to get 2 AIS sessions a week myself, even though I don't have any pain, because it just feels great. Another question.
Judy asks, can prolotherapy be effective for people with neurodegenerative diseases or conditions such as MS?
In my experience, no. I don't think so. I've never seen it that effective, except if it's in the neck, and really the MS is sometimes mistaken, some of the symptoms, because there's intervertebral pressure in the neck causing a delayed or diminished blood supply to the brain. So I've seen MS-like symptoms go away, but they didn't really have MS. MS, active isolated stretching, does phenomenal for MS. I've treated a number of people who have that condition, and I even got one person to be able to do a bit of crawling and walking when she'd been in a wheelchair for 4 or 5 years. It's a phenomenal technique for people who have MS to bring back some function and to prevent them from losing function, and incredibly rewarding to work with somebody like that. I remember a woman came up to me in a wheelchair after just seeing her, I think 3 or 4 times. She started crying that she had not been able to even turn over in bed or crawl to get something, and that had changed after like 3 or 4 sessions, and it was just sort of amazing to her. So I don't usually believe anything until it happens to me. So you got to try it for yourself to see that, how effective it is. Next question.
And Tracy asks, what's the home care for the client to do daily for SIJ ligament realignment?
Well, they do a couple of exercises. One that's sitting in a chair, at the edge of a chair, clasping their hands in front of them, and slowly going down under the chair in constant motion. And what that does is it prevents the return of the scar tissue, because as soon as the client leaves your office, their body is starting to produce that scar tissue again, all day, all night, to try to bind things up. So that's why you have them do those exercises every day, 50 times in the morning, 50 times at night. It just takes 5 minutes. And the new ligament, the new scar tissue that's forming within the ligaments is really weak. It's like a cobweb. And so, with a cobweb, you can just brush it aside with your hand or a broom. And so by doing those mild stretches, you prevent the scar tissue from forming again, the scar tissue you broke up. And as well as that, it strengthens the ligament fibers that have not been in use for a long time. So doing daily exercises, and if a person has an iliolumbar ligament, we give them a different exercise, and then we start giving them daily stretches that they do for their hamstrings and their quadriceps, which makes you very vulnerable to lower back pain if those are really tight, because you're not taking the slack or the stress in your thighs, but you're taking more in your low back. Next question. We're going to take a few more, and then we're going to say sayonara, and I'm going to go back to sleep because I got up at 5 in the morning to talk to you guys. Go ahead.
I do appreciate it. We appreciate it, Ben, very
much. No problem.
If the pain has been chronic for 20 years plus, does this mean that the healing process is going to take a really long time as well?
That's an interesting question. I've had people who had pain for 20 years, and some of them I've helped very quickly, like in a month or so, because no one ever found the right place. People start crying when somebody actually puts their finger on the thing that hurts and makes it hurt at the moment, when they've been to all these different doctors and therapists, and no one actually ever touched the thing that hurt them. So I put my finger on it, and they jump off the table, and they say, good, somebody found it. So if it's really near the surface, you can get rid of it more quickly. And if it's not, as tough scar tissue, and of course, if it's been there for 20 years, in most cases, it's going to take you, 3 months, maybe 4 months, rather than a month or 6 weeks. But that's not that long if you've had pain for 20 years. Now, I'm not saying it can help everybody, because something I did mention is your sacroiliac ligaments, as I showed you in the beginning, go very deep. And if it's in your interosseous ligaments or your anterior ligaments, which are, 1, 2, 3 inches deep, depending on your size, you can't get to that with your fingers. They need to have it broken up with xylocaine and a needle with a very skilled doctor, and they need to have it realigned, and then they need proliferant. But in most cases that I see, people have it near the surface, whether it's 20 years or 2 weeks, and you try it. And if my watchword is, if the person is getting better within 6 or 8 treatments, then I know this is working, and I keep going until they plateau for a month, and I know that's all I can do. And usually they're pretty much out of pain, and if they're not, I send them for proliferant therapy. Let's take one more question, Jeff, and then we're going to probably sign off, and you can talk a minute about how they can reach you if they want to take the workshop in Melbourne or Sydney, or maybe have some enterprising people that want to take it in both places. So,
sure. One
more.
Should you give AIS to clients rather than 30-second stretches? That's from Peter.
Yeah, I would give people AIS stretches, I wouldn't go stretching for long periods of time. I would have people in the stretch, out of the stretch, no more than 2 seconds. So what you're really doing is you're putting tension on the ligaments. And if you're stretching your hamstrings or your quadriceps or anything, you don't want to go beyond 2 seconds, because then the stretch reflex kicks in and the body contracts, and it's like driving a car with the brakes on. So at least in my experience, doing the AIS type stretches are much more effective than any others that I've ever seen. So hi to all of you that I saw in Sydney last time, and I hope to see you again, and hope to see all of you new folks out there in both Sydney or Melbourne. So you want to tell them how they can get in touch with you to find out about the workshop and cost and place and all that sort of stuff?
So thank you very much, Ben, and
Okay.
I look forward to seeing you in November.
Great. And let me make sure that I get you access today for those little clips on the low back for people to do to access. Okay?
All right, thank you. And thank you for everyone attending. It's a great turnout, absolutely fantastic.
Okay, great. Bye, everybody.